Hi class, this is Dr. Heather Austin Robillard, and we have reached the section of what do we do to treat individuals with eating disorders. In this lecture video, you're going to learn about the different types of individual therapy approaches that we can take towards disordered eating patients. As a therapist myself, one of the things that I find the most important when it comes to working with clients is the Therapeutic Alliance, or the relationship with the therapist and the client. A therapeutic alliance is the relationship between the therapist and the client, and it needs to include a feeling of trust, support, acceptance, and honesty. Without these, it's very hard to do any other kind of treatment approach if there is not a therapeutic relationship that is strong. Common factors of therapy: the therapeutic relationship is one of the core ingredients in order to create change within the client. The relationship accounts for up to 40% of a successful outcome. So the most important thing you can do is be there in the room and have a good relationship with your client. So as a clinician, how are you able to create a therapeutic alliance that can create successful outcome? Clients actually don't care how much knowledge you have until they know how much you care about them. So in order to do this, you can use validation, like, I can see that you're really upset and I understand how you're feeling. Or empathy: man, you look like you're having a really hard time with this and this just hurts my heart. Confrontation: being able to confront their feelings in a non-judgmental and accepting way. And then, of course, using self as a therapist work, being able to identify certain parts of yourself that might be hard to work with a client or might be triggering for yourself. So some of the treatment approaches we're going to be talking about today are the ones on the slide. There's the psychodynamic approach, cognitive behavioral therapy, which has lots of evidence-based efficacy when it comes to eating disorder treatment, interpersonal therapy, dialectical behavior therapy, or DBT, the addictions, or the 12-step model approach, and then professionals in recovery. First, let's take a look at one of the most common therapy approaches used in treatment today, which is cognitive behavioral therapy, CBT. This was developed by Aaron Beck in 1976. It's utilized as a short-term, goal-oriented treatment model. The assumptions of this model include that feelings and behaviors are created by cognitions, or our thoughts. Therefore, our goal for CBT is that therapists help individuals identify their cognitions, and especially those cognitive distortions, and choose to not act on them or replace them with more positive cognitions. This therapy approach is a very structured model of therapy. It utilizes homework, journaling, monitoring thoughts outside of sessions. So there's worksheets that can be provided to clients. One of the most influential and well-validated models of psychotherapy. It's demonstrated for efficacy in the treatment of depression, anxiety disorders, substance abuse, and eating disorders. In CBT, one of the primary intervention is helping individuals understand their cognitive distortions. And so there are 13 cognitive distortions. Some of them might include dichotomous thinking. This is kind of if or that. So if I don't run, I can't eat. I either run for an hour or it's not worth it at all. Selective abstraction: if I can go to the gym, I am happy. If I feel great when I exercise, so if I exercise, I will never feel depressed. Magnification: if I can't exercise, my life will be over. If I don't work out today, I'll gain weight. Overgeneralization: like my mom, people who do not exercise are fat. And then superstitious thinking: I must run every morning or something bad will happen. I must do 205 sit-ups every day. I can't stop at 1 hour and 59 minutes. It has to be exactly 2 hours. Some other cognitive distortions include arbitrary inference. People who exercise get better jobs, relationships, and so on. People who exercise do not get sick as much. Or discounting. My doctor tells me not to run, but she is flabby, so I won't listen to her anyway. Personalization. People are looking at me because I am out of shape. People admire runners. I'm a runner, it's who I am, I would never give up. So when it comes to using CBT for something like anorexia nervosa, we need to look at some of the core ingredients for this. The core maintaining mechanism of anorexia nervosa is the significance of control over eating, shape, and weight. The eating disorder symptoms are maintained by this interaction between cognitive disturbances and behavioral disturbances. So I think this way, therefore I must do this. The model recognizes that anorexia development involves multiple factors, which is addressed in psychoeducation. So in CBT for anorexia nervosa, there are 4 phases of treatment. Phase 1 is the orientation to CBT, so beginning to introduce them to CBT, the cognitive distortions, some psychoeducation. Then we're engaging and motivating them. In phase 2, we are utilizing the core cognitive and behavioral interventions for anorexia. Phase 3 is a schema-based cognitive therapy and related clinical issues. Schema-based means we're starting to challenge those messages they've learned and said to themselves for many years, starting to challenge them and helping them with those, turning them into different schemas. Phase 4 is ending treatment and creating relapse prevention. So let's look at those different phases. In phase 1, we're going to introduce the client to what are some of the assumptions of CBT and the therapy structure. We also want to be making sure that we're building a therapeutic alliance with the client. The structure of the session for the first phase is to discuss weight assessment and the discussion of their weight status, how they view their weight, a review of their self-monitoring techniques, and between session work, so their homework, we're also going to build an agenda or look for goals. In this section, we're doing psychoeducation of the consequences of anorexia and the numerous factors that lead to its development. The weight monitoring includes weekly weigh-ins with someone else to monitor and creating a personalized weight gain plan. The self-monitoring includes food logs, social and emotional experiences, and even some mood calculating. In phase 2, the hope is for weight gain, understanding why it's necessary, writing meal plans, and using education as a way to understand how to write meal plans. Strength building, moving beyond just weight-related and eating behaviors to the development of other skills and strengths that are needed to increase self-esteem. In this phase, we're also making sure to challenge dysfunctional thoughts or those cognitive distortions. We're trying to prevent any further weight loss and addressing body image disturbance. They may be doing body checking or body avoidance, so we're checking on those and addressing those issues. And then we also need to make sure that we're combating any excessive exercise that might be replacing the restriction of food intake. This is an example of some of the ways that we might challenge these dysfunctional thoughts. First, we have them describe a situation, like they skipped lunch and dinner on Tuesday. Then we want them to specify the feelings that they had during this time. They felt frightened and anxious. Then we're going to help them identify the specific dysfunctional thoughts that preceded this problematic behavior. I thought if you eat anything, you are going to get fat and you had too many calories at breakfast to have any more today. Now we want to challenge those dysfunctional thoughts by asking 3 questions. What is the evidence for or against these thoughts? Is there an alternative way of viewing the event? And what is the effect of having this thought? The more calories you consume, the more weight you gain. Our bodies burn a certain number of calories even without exercise. That's against. I was stressed about school and felt more anxious than I have lately. Anxiety made me feel out of control. The third question, this thought makes me go back to restricting my food intake. In phase 3 and 4, for phase 3, we are looking for affect regulation and interpersonal effectiveness skills. This includes treating individuals with binge eating and purging. using the therapeutic relationship to address any kind of maladaptive thinking or schemas that increase the chance of eating disorder versus decrease. In phase 4, we're working to prepare for termination, letting up on their perfectionism and starting to accept their body as is, anticipating the loss and that relapse is possible, noting risk factors or triggers in order to prepare and prevent relapse. CBT is similar for bulimia nervosa and binge eating disorder, but it's tailored to these eating disorder symptomology. It focuses on the process that maintains those eating disorders and not necessarily what led to the development of the eating disorder. Some of the assumptions for the core eating disorder maintaining mechanisms include a dysfunctional scheme for self-evaluation. This is based exclusively on their weight or shape or size and their ability to be in control of these factors. There's also an assumption of dietary slips and binges in response to day-to-day stressors. They may have temporarily ameliorate the negative mood states, or they may distract from aversive thoughts. Those who purge, maintaining binging through belief that purging minimizes their weight gain. The treatment must address that the patient's dieting behaviors, their over-evaluation of shape and weight, and the sensitivity to external events and negative moods. There's also additional potential maintaining mechanisms that we need to address in treatment. The typical length for CBT is 20 sessions. This is 4 stages, similar to CBT and anorexia. Stage 1, engage the patient, assess eating disorder, establish self-monitoring like weekly weigh-ins, psychoeducation, regular eating, and involving significant others to their eating. Stage 2 is review progress, revise formation of conceptualization of the development of their eating disorder, and design for Stage 3. Stage 3 is the main part of treatment, and it focuses on those mechanisms that have maintained their eating disorder. In Stage 4, 3 sessions over a 5-week period, so we start to separate them a little bit, and evaluate the client's ability to maintain changes over a course of termination process and minimize the risk for relapse in the future. So it's critical to address any over-evaluation of weight and shape. This is the leading factor to relapse. So focal areas of this intervention include identifying those over-evaluation and its consequences, developing marginalized self-evaluation domains, addressing body checking and avoidance, addressing feeling fat, exploring the origins of their over-evaluation, and learning to control their eating disorder mindset. Another treatment approach is the Interpersonal Therapy, or IPT. This was developed by Gerald Klerman in 1960s and is thought to be brief and time-limited. It focuses on creating change by addressing interpersonal relationships. The goal is to help the clients improve their communication and interactions with others. Some of the interventions help clients gain awareness of and their ability to express their emotions. So they might learn how to identify secondary versus primary emotions, learn to understand what is evoking that emotion for them and how to express it to others, and what emotional baggage from their past relationships are they holding on to. The rationale for interpersonal therapy with eating disorders is that clients with eating disorders often have a number of interpersonal issues that play an important role in the onset and the maintenance of their eating disorder. This therapy has only been validated currently with bulimia nervosa and binge eating disorder, and not necessarily anorexia nervosa. Here's some of the research findings about individuals living with bulimia nervosa or binge eating disorder and their interpersonal functioning. They have difficulty with past social experiences or problematic family histories, and they have specific interpersonal stressors in comparison to those who are non-bulimia nervosa or binge eating disorder. There is a sense of loneliness or lack of perceived social support, poor self-esteem, and social adjustment, and difficulty with problem-solving skills. They have a heightened sensitivity to interpersonal interactions as a common characteristic of those bulimic tendencies. The interpersonal distress may trigger overeating and potentially perpetuate binge eating. The primary aim for interpersonal therapy is to help patients identify and address current interpersonal problems in 4 social domains: interpersonal deficits, interpersonal role disputes, role transitions, and grief. This treatment typically includes about 15 to 20 sessions over a 4 to 5 month period. The initial phase, or the first 5 sessions, includes the assessment of the symptoms, an interpersonal inventory, and interpersonal formulation. Then the immediate phase, or 8 to 10 sessions, this is the work stage of the treatment. It helps the client understand the connection between their interpersonal functioning and their eating disorder behaviors and symptoms. And it addresses those 4 social domains. Then there's the termination phase. This includes certain therapeutic techniques like a therapeutic stance, focuses on the goals or goal-oriented direction, and making connections, redirecting issues that are related to their eating disorder symptoms. Some other areas of intervention include poor self-esteem, the thinness myth, feelings of emptiness, the need for distraction, dichotomous thinking, a desire to be special or unique, and the need to control. This concludes the approaches to individual therapy and how it can be helpful to individuals who struggle with some sort of disordered eating. We will next learn about group therapy and family therapy.